Hello, everyone. My name is Dr. James Ford, and I'm giving this presentation on behalf of myself and my colleagues at UC Davis Health. Today, I'm going to talk to you guys about universal screening for hepatitis C virus in the emergency department using a best practice alert. Our ED-HCV screening program was supported by a grant from Gilead Sciences. Apart from this funding, the authors have no other disclosures. Hepatitis C is responsible for 2 million chronic infections in the United States, making it the most common bloodborne infection in the country. As you know, there are many devastating clinical consequences of chronic HCV, including cirrhosis and hepatocellular carcinoma. As such, in 2020, the United States Preventative Services Task Force recommended universal screening for hepatitis C in all individuals aged 18 to 79. Previous studies in the ED have shown that universal testing has been associated with an increase in HCV diagnosis compared to conventional opt-in screening. In this study, we aim to evaluate the efficacy of an ED-based screening program in identifying patients with hepatitis C. We conducted a retrospective 6-month cohort study following the implementation of an EHR BPA. Our study setting was a single tertiary academic medical center in Northern California, and our study population were adults over the age of 18 with no previous hepatitis C viral load within our electronic health record. Our primary outcome was hepatitis C antibody seroprevalence, and our data analysis plan consisted of using simple descriptive statistics, and comparisons between groups were performed using simple linear regression. This is a table going over some basic patient characteristics for our study cohort. There were 16,719 patients tested for hepatitis C. The median age of our patients was 47 years. And the gender distribution between males and females was about the same. Almost all of our patients were screened using the best practice alert. This is a table demonstrating our screening results stratified by screening modality. We see that for the hepatitis C antibody seroprevalence, it was a little bit higher in the clinician-initiated group. This makes sense because if you think about somebody who's being targeted by a provider, they likely come from a high-risk background or population, and therefore their pre-test probability of having hepatitis C is likely higher. We saw this trend continue for patients that had viral loads drawn as well. And we found that in patients that were antibody positive, they were more likely to be older and male if they were in the BPA group. So in conclusion, we found high seroprevalence for antibodies and viral loads with regards to hepatitis C in both the BPA screened and clinician screened individuals. We think that the HCV BPA may help in the catchment of HCV infections in older patients. And we believe that use of a routine opt-out testing algorithm using a BPA is an effective way to screen patients for hepatitis C in settings where universal screenings are not otherwise implemented. Here are a list of our references, and thank you all for tuning in.